Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, your host for today and head of marketing here at Mingle. Our topic is tips for MIPS success before year end. Mingle Health is your partner in the transition to value-based care and helping you improve what matters. We help you save time, improve quality scores and outcomes, and increase earnings. Some housekeeping items before we get started today. This webinar will be recorded. The slides and recording are going to be sent by email later this week. You can also download the slides and some additional handouts in the GoToWebinar handout section of the tool we're using today. We do encourage you to ask questions throughout the webinar using the question box. We're standing by to answer them throughout the presentation, and then we're going to leave a big chunk of time at the end for the Q&A. So please do get your questions in early so we can make sure that we see them and prepare for them. We're going to get to as many as we can. So let's go ahead and dive into the presentation. Our presenter today is Bridget Whitney Gallagher. She's the manager of client services here at Mingle Health. She's been with Mingle since the beginning, and she's helped hundreds of practices succeed with these value-based programs. So you're going to be in good hands today with lots of tips to make sure you're on top of everything you need to be before the end of the year here. Before I hand it over to Bridget, we are going to do a quick poll just so we can gauge where everyone's at with MIPS so far this year. So it's going to take over your screen here for a minute. We're going to keep this poll open for about 20 more seconds. Thank you, everyone, for filling that out. Just to give us a quick pulse of where the audience is at with your current MIPS project for 2020. Okay, thank you. So I'm going to go ahead and pop those up on the screen here so we can all see. So we've got quite the mix here. Several folks are getting things ready to go. Some folks are thinking about what they need to do, and others are have already reviewed their quality measure performance. So that's great to hear. Thank you all for participating in that quick poll. And now over to you, Bridget, for the presentation.
Thanks so much, Charles. Hi, everyone. I'm so glad to be with you today, morning or afternoon, depending on where you are. The content for today, we're really going to focus on being successful in the MIPS program. So we're going to talk about what's at stake and really what are the things that you as a practice or provider can do to make this program really work for you. So this is where we are in the performance year. For MIPS 2020, we are just starting the fourth quarter. So we're getting down to the last 90 days of the performance year. We know that the MIPS program is part of the quality payment program. And there are two pathways in the quality payment program. We have APMs in the dark green here, which is the alternative payment model. And then we have MIPS, which is where we will be focusing on today. We know that quality payment programs and quality reporting in general is here to stay. And certainly, I know I've seen it shift and change over the years, and I'm sure you have too. But we know that one way or another, quality reporting always comes back around. So in the MIPS program, we have 4 performance categories, and each performance category is worth a different percentage of your total score. So the percentage that it's worth has changed over the years, as is indicated by this graph. You can see that here in yellow, we have quality coming in at 45, cost at 15, improvement activities at 15, and promoting interoperability at 25. Those weights change from year to year. It's one of the things that we keep you updated on. And of course, with the recent public health emergency, those weights have shifted as well. Whoops, excuse me, while I click through this, I got ahead of myself. All right, so let's talk about what's at stake. So I want to be clear that most of this slide is set in stone, or at least half of it, and some of it is subject to budget neutrality. So we have 2020, which is where we are living at the moment. We know that in the program year for 2020, if you are required to participate in MIPS and do not, your practice will be penalized 9% of your Medicare Part B payments that would be made to you in 2022. The theoretical part of the slide is that positive adjustment. Theoretically, it could be 9%, but remember that MIPS is a budget neutral program. So the money that is collected in penalty is what is available to be redistributed in incentive. There are some bonus monies available, and we can discuss that as well. So we know that we certainly want to avoid that penalty. That's very important. I'm sure every practice could use a bit of an incentive. So let's talk about how to get there. So we're going to go through these 6 tips for success. The goal here is really to help you understand how you can make the MIPS program work for you. So the first thing is decide, what do you want to get out of MIPS? Really, you have an unlimited amount of options about what you want to get out of MIPS, but these are the three to focus on. Are you focusing on just avoiding the penalty this year? Do you want to maximize your positive adjustment, get your score as high as it can to earn that incentive? Or are you preparing for APM participation or participation in other programs and using the MIPS program to help you prepare for other activities? In your practice and even throughout the year, the goal might change, and that's okay. It's important for you to understand what it is you're working towards so that you're putting the right amount of effort to meet your goal. Oh my gosh, this is the tricky one, understanding your clinician's eligibility. So we've put up on the screen here the qpp.cms.gov participation lookup. Anyone who has not gone to this website and put in the NPIs of their providers absolutely should. This website is what CMS believes to be accurate about your providers. So this is the way for you to understand what CMS is expecting from you and your practice and how they're going to score you. There are different pieces of information that this website provides. Certainly, please call anyone here at Mingle Health if you don't understand the information you're seeing on the website, and we can certainly walk you through it. This is the foundation of your decision about MIPS reporting. Who has to report and how all comes from this QPP lookup. I want to go into a little bit more detail here. The lookup is giving you eligible clinicians, which are subject to MIPS. It's going to tell you if you are not eligible because of a variety of different issues. It's going to tell you if you're subject to other programs, like an advanced APM, and that's identified by the QP status here. It's also going to give you your special statuses, and the special statuses are where your scoring may be different than the traditional percentages that we looked at before. So we have a couple important date ranges to keep in mind. One is in purple here, this determination period. This is the 2 timeframes that CMS uses to collect the information about your practice to determine those special statuses. So this is going to determine if your specific providers have met the low volume threshold, which you can see listed out there. It's going to determine if they are non-patient facing or hospital based, or if they have other special scoring situations like ambulatory surgical center, facility based, or other sort of designations. I do want to call out this qualifying participant or QP status. That is a different date range than the determination period. So the QP status establishes if your provider is subject to MIPS or if they're subject to another advanced APM process. That status changes throughout 2020. It changes throughout the program year. So you could become a QP or stop being a QP, and there are 3 different snapshots throughout the year. So you could be a QP, not a QP, and end up a QP again. That final status is going to be available in this QPP website in December. So it's super important that anybody reporting MIPS or APMs or even just interested in quality reporting at all explores all of your NPIs and really reviews them closely in December. That's when we will see the final QP statuses. That's when we'll get the data from the second determination period. And of course, we all know statuses change, so we want to make sure that you're doing the best possible process for your organization once we know how you're actually going to be judged by CMS. Okay, let's talk a little bit about COVID-19. So we're in healthcare. There's no way that we haven't been impacted. This is a health emergency and we all work in healthcare. So CMS has responded to the COVID emergency through several different ways. They altered the scoring process for 2019, and they are allowing for an extreme and uncontrollable circumstance application in 2020. This is an option for practices that are significantly impacted by the public health emergency, where they could essentially apply to be exempt from a specific category in MIPS, including all of the categories, so to be completely exempt. This is an application process. You would put your application into CMS and they would review it and approve or deny. And the deadline for applying that application is December 31st. This is the information. I'm a slide ahead of myself, I apologize. This is the information on that application. You do have to have a HARP account. That's how you get to the application. You do have to justify how you're being impacted. Again, the application is due by the end of the year. CMS has said that they may not be, depending on the volume, they may not be able to share the results back with everyone until January of 21. Of course, if they get inundated at the end, they may have to take some time to be able to get back to folks. All right, the next way to understand how CMS might score you and prepare for success is to understand how you've done in previous years. Reviewing your prior year feedback report is really the best window into understanding exactly what happened to your submission, how it was scored, how your practice was perceived by CMS in previous years. It gives you just the basic scores. It also gives you a lot of deep level detail. One thing that I think is really important to note is that the cost category, which is automatically reweighted for some practices and not for others, and is completely calculated by CMS based on your billing. The cost category and all of the information about how CMS sees your practice is available in your feedback report. It is not easily available any other way. So utilizing this feedback report to really dig in to your cost category, understanding which patients are being attributed to you for cost, how you're being scored in the cost category, and what your practice can do to move the needle on that. All of the base information for that is going to come out of your feedback report. Again, to access your feedback report, you need to have a HARP account. And if you don't have a HARP account, or if you're having a hard time accessing, you would want to go ahead and call the QualityNet Help Desk. They administer this program, this HARP account program, so they would be the ones to help you. Okay, so once you know how you've been scored in the past, the next step is to see where are you at right now. We are 3/4 of the way, just over 3/4 of the way through the year. So you certainly have had a lot of billing encounters, a lot of performance has already been completed. You've seen and cared for patients. And we would encourage everyone to report on the care that you have already given. By reporting on the care, by sending us your billing data and your performance data, we can give you a snapshot about where you are right now. So granted, it's not the entire year of data and things are subject to change, but if this is what your performance looks like right now, you're in pretty good shape. We can see through the visit dates here, we're looking at about just over half a year of data, and this practice has reported on every single patient. Their performance rates are quite reasonable, and we've calculated out if this doesn't change their performance and bonus points here. This information is key to changing your score during the year. If you look at this and realize that there's a measure that you're performing unexpectedly on, or you know you do every time, but it doesn't look like it, that's really an opportunity to make changes to a workflow. Maybe you need a reminder for some of your staff. That's the opportunity to dig in. And that's where your Mingle consultant can really step in and go through every measure with you and be very clear about here's the score, here's the data we received that is getting you that score, and here's what you could do to change it. In addition to the changes that you make to your score, CMS also makes some changes to the measures year over year. So that's the other part of the equation. We have a great report that's available right now in your quality portal in the Mingle dashboard that shows you how you are currently performing, how you performed last year on a particular measure, and if that same performance happened this year, how would it be scored? One of the things to highlight in this report is that the benchmarks associated with measures change year over year. So if you look, for example, at our measure 112 here, the performance rate for 2019 that earned 9.7 points, this year would only earn 7.9 points. So it's important to note that those benchmarks change. This report is also really helpful to show measures that have become topped out, measures that didn't have a benchmark previously but now do, measures maybe that have changed in their reporting requirements as far as the scoring piece is concerned. So it's a really good snapshot, again, to just say, if everything was the same as last year, what would I be looking at? All right, so we've talked about quality, we talked about how to improve quality and some different things to do around quality. Let's talk about improvement activities. One of the great things about the improvement activity category is that in most cases, these are activities that your practice is doing anyway. These are activities that are really best practice across a lot of different disciplines. One thing to be aware of this year is that we have several activities where the activity detail, or description rather, has changed, as we see here, but the activity name hasn't. So because you're able to report on the same activities year over year, it's really important to make sure that you're paying attention to that activity description. Subtle changes in the description really could change if the activity is a good fit for you or not. If you find that the activity isn't a good fit, don't worry. There are 90-something other activities. And at Mingle Health, we have several tools to help narrow that list down to activities that are applicable to your practice based on different circumstances. Maybe you're a small practice or a specialty. We also group we group activities with activities that are really straightforward and most practices can accomplish, all the way to activities that are very, very difficult and may not apply to many practices. In 2020, to earn the points for group reporting for your activities, you have to have 50% of your eligible clinicians do the same activity for a 90-day period. And I have a little mental asterisk here around 90 days. Most activities are a 90-day period. There are, I believe, 2 activities that are a longer time frame. So again, that's just something to be very mindful of when you're selecting your activities. Also, for the first time in 2020, improvement activities could be, we may need to have documentation to validate the activity. So this could be as simple as a letter of participation, a screenshot, other things like that. And certainly your consultant can discuss that with you. In the activities list, the 2020 improvement activities list, we have a column from CMS that details out what some validating documentation might be. So be sure to review that with your practice or with your consultant if you have any questions about that part of improvement activities. All right, this is the time of year to review PI. The PI category hasn't changed dramatically. The measures are very much the same. There are some subtle differences around some exceptions, so make sure to go over it very clearly. My recommendation to be successful with the PI category is to first understand if you are eligible to report the PI category. And if there are some people in your practice that are eligible and some that are not, make sure you discuss that with your consultant so that you're providing the information and the data that's needed for the category. The next thing to do is to go to the Chapel website and make sure that you have a 2015 certified EHR and that you have the 2015 CERT ID. Usually those CERT IDs can be found by emailing your EHR or opening a support ticket with them. Some systems have them embedded in the About section of the EHR, some don't. That 2015 CERT ID is a requirement to submit any data in the PI category. So if you're planning to report PI, that CERT ID is a must. You also want to confirm with your vendor that your PI dashboard is up to date. The measures haven't changed dramatically, but they have changed subtly from last year. So your vendor would have had to do updates to the system to make sure that they're capturing the right data points. It's also important to understand if you can get your PI data, get access to it in a way that you will need for reporting. For example, if you are planning to report individually, you want to make sure that you can access your PI data or see it in a PI dashboard at a provider level as opposed to the group level. So that's one thing that we've heard tripping people up in the past. So it's better to just make sure you understand and have access to what you need beforehand. If all else fails, or if you're having really significant issues in the PI category, there is a PI hardship. The PI hardship has been in place for several years, and because it's been so long-standing, it really shows that CMS understands that most practices know how to take care of patients, right? That's the quality category. Most practices do a great job creating efficiencies and staying up to date in their practice. Those would be your improvement activities. Most practices struggle getting data in and out of their EHR, and that's really the PI category. So that hardship is absolutely available for practices that are having technical issues with their EHR. There are all sorts of reasons why you could apply for that hardship, and your consultant can really help guide you through that process, find the right reason, and understand how the different options for the hardship might apply to your practice. All right, so this is a slide actually from a webinar that Dr. Mengele put on previously, and I really, really like it. I want to kind of talk about MIPS as a way or a program that you can use, a pathway to value-based care. We know value-based care isn't going away. We know that in order to improve things, we have to measure things. We know that better healthcare at a lower cost is the goal of everyone. And the MIPS program is a way that you can kind of start out on a path or use it as a stepping stone to move to maybe other value-based care programs. It's also a great tool if you want to make other types of improvement in your practice. It's kind of a good foundation. All right, so I'm gonna do my little quick plug here. At Mingle Health, our goal is to be your partner. We know that this is a very challenging program for a lot of folks, and we certainly can't make it easy for everyone, but we do want to make it as easy as possible. And one of the ways that we help you do that is by guiding you every step of the way, through understanding what your goals are in your practice, seeing what plan we can put in place to meet those goals, understanding the different categories and all the regulations and ins and outs. Our job is to be MIPS experts, and your job is to take care of patients. So let us do the hard part of figuring out the regulations and getting things set up, and you do your job to take care of your patients. You can reach us several different ways. Our website has a chat feature, so you're always welcome to jump in and chat with anyone. And certainly anyone who's working with us has a consultant that you're always welcome to reach out to.
Thank you so much, Bridget, for that concise dive into what folks need to be thinking about here as the end of the year approaches quickly, faster than we might hope. So now's the time for the Q&A portion of the webinar. We have a couple questions that have come in that we're going to go ahead and jump into, but I would encourage you to get your question into the queue so we can get to as many as possible before the end of the session. So I thought a good place to start, Bridget, is we have a question from Melissa that says, we are working on reporting, but mid-year we merged with another practice. How do we submit?
Oh man, this is a very common question. So the answer, which is not quite satisfying, is it depends. The MIPS eligibility is based on a TIN and NPI combination. So that would be your practice and your providers. If you have essentially abandoned your old TIN and will not be billing under it moving forward, you may need to report under that TIN, you may not. And depending on if you are moving to an already established TIN or moving to a brand new TIN, you may need to report or not. This is one of those questions that we really have to get into the details of, because the nuances are just all over the place. At the end of the day, the most important advice I can give you is check the QPP website and call us. There's a lot of nuance here, and certainly we want to help you make the best possible decision and make sure you're safe from the penalty, no matter what happens moving forward.
All right, so hopefully we answered your question. Please let us know if you want to ask a follow-up. And if we want to go ahead and dive in, Bridget, to the pre-submitted questions.
Sure. So we had a question from Jonathan that said the max penalty is 9%. If I meet some but not all of the requirements, is the penalty smaller? And the answer is yes. The penalty ends up being a sliding scale of between 0% penalty if you hit 45 points and a 9% penalty if you hit 0 points. So depending, say you hit 15 points or 20 points, it wouldn't be the full 9%. It would be adjusted to be in between. We do have some very few practices that understand that for them the penalty is not avoidable, so they might participate in ways just to help mitigate that penalty so it's not the full 9%. All right. Larry asks if we can explain the reweighting options that allow practices to reweight different categories. And the answer is yes. And I have a table here to help explain it because it can be quite complex. So we have several different scenarios where no reweighting happens. You might need to reweight one category or even two performance categories. The reweighting option really comes from that extreme and uncontrollable hardship application. So if you are a practice who identify that because of the impacts of COVID, let's say promoting interoperability is simply not something your practice can be successful with this year, you could apply to have just promoting interoperability reweighted, and the 25 points that you could have earned through promoting interoperability now get reweighted into the quality category. This is part of the slide deck, so it's absolutely available to everyone. This is also information that's available on the QPP website, and of course your consultants can guide you through this. Depending on the circumstances of your practice and which categories are reweighted is really how you could understand where those points are going to end up. Okay, when should I get started with MIPS reporting for 2020? The answer is now, if not sooner. Really, when we talk about working together to support your reporting for any given year, we want to start as early as we can. The more time we have, the more data we have, the better opportunity we have to help you move that needle and really end up with your most successful score. Okay, George asks, how do you select the right measures for your practice? This is a big one. This is really one way that at Mingle Health we really can impact how MIPS works for you. So the short answer is that we help you select measures based on how you bill. Every measure or CQM, quality, CQM, every measure has its own eligibility criteria, which is a combination of demographic information and billing information that would make a patient or a visit eligible for a particular measure. So you have to start with the measures you have eligibility for. And then based on that information, we give you your measure analyzer and we review that together to help you decide the measures that are meaningful to your practice, measures that are going to be the least burden for your practice from a data perspective, and the measures where you can earn the most amount of points. Some measures are capped, so you can only earn 7 points. Some measures are very challenging. Some measures are easier. And so through that conversation around your measure analyzer, we really explore what's going to work for your practice. One thing that I really like about getting started early is that maybe we select 15 measures and you look at those and you talk to your providers about them and we see what data is accessible through your system. We might only end up submitting 6 or 7, but it gives you an opportunity to really think about how this is going to work for your practice. And maybe it gives you measures that you want to work on moving forward into the next years that are meaningful. That is the end of my, oh, I'm sorry. I see a couple questions have come in while I was answering those. Sorry about that. Let's see, we have a question from Michelle that says, if we have reported with a great score the last several years, what happens if you claim an exemption for all categories in 2020? What happens, Michelle, is that you will not receive any payment adjustment, positive or negative, in the 2022 payment year. So you basically just get to take a timeout for this year. That's what that exemption is. It's only applicable for the year. So if you do need it several years in a row, you need to apply several years in a row. It doesn't negatively impact any other reporting that you may have done previous years, and it also doesn't impact any reporting that you may be doing through other programs. Okay. Kathy asks, our practice was purchased and we are waiting until November to determine eligibility. Since we do not know eligibility yet, is it possible to obtain a feedback report? The answer is yes, Kathy. Your feedback report is based on whatever reporting took place the year previous. So in this case, 2019. Your feedback report data may or may not inform what will be happening this year, because you'll have a different circumstance for your practice, maybe different providers, etc. Okay, another Kathy asks, do ECQM data sets have requirements around author and date and time? Some providers don't complete MIPS during the visit, but finish notes later on in the date or on a different date. Do they get penalized if not doing during the visit? So for ECQMs, that is a quality measure that is calculated through your EHR system. So the kind of short answer is it depends on how your EHR system has your particular ECQM calculation set up. In general, there is not a penalty associated with not completing the quality action at the time of the visit, unless it is a measure that is required to happen at the time of the visit. For example, medication reconciliation is required to have happened at the time that the patient was seen, but something like following up on scheduling colorectal cancer screening doesn't necessarily have to happen the day the patient was seen. If you follow up with them a week later or write a referral, that would still satisfy, even if it doesn't happen on the same date. Where it is in ECQM, the final decision about what gets added to your numerator and denominator is going to be based on the workflows that are set up with your EHR.
Great questions, everyone. Thank you. We do have a little bit more time, so please do, if you're sitting on a question, get it in now so we can see that in the queue. We had another question come in from Becky. How can specialists get more measures appropriate for their specialty? Cross-cutting measures are not always appropriate.
Yes. Oh,
very
man.
common question here.
Yes. And we have some specific specialties that are really struggling to find measures. So the answer to your question, Becky, is really there are a variety of ways to do it, depending on your specialty. If you are a specialist who sees patients face to face, like a cardiologist or a podiatrist or dermatologist, some measures you could get credit for, even if you aren't the person doing the particular care. But if the patient is receiving good care at other locations, sometimes you can get credit for that for some measure. So that's something that a consultant could explore with you. If you are a specialist who is not patient-facing, like a pathologist or radiologist or anesthesiologist, you have a much harder time. My recommendation for this year is to report what you have, which sometimes is not 6 measures. And in that case, we would want to explore the EMMA clusters. So an EMMA cluster is a set of less than 6 measures that CMS has said, if you can't report 6 measures, you could try the smaller set, and we won't penalize you for not having other measures. So that might be an option. The EMMA clusters for 2020 have not been published for CMS at this time. We do expect them very soon. I was on a vendor call last week and we were told they were on the way, but unfortunately, I haven't seen them yet. So the Emma cluster might be something to explore. Another option is more of a long-term option, is to really petition to CMS, to your medical societies, and to anyone who will listen, your governor, your congressman, really petition for your medicals or for your medical specialty. This clearly wouldn't help you looking to report for 2020, but it is a really important way to make sure that you can still be successful in this program. CMS has some things coming in the next couple of years. We saw a preview in the proposed rule for 2021 talking about the MIPS value pathway, or MVP. That might be a different way that this program could work for specialties, but the devil's still in the details on that one. So in the short term, let's see if we can help get you the best score possible with less than 6 measures. And in the long term, let's focus on making sure that this program can still be relevant for all specialties. Oh, good. I have a question from Ashkin. Most quality measures are directly related to primary care settings. We are an ophthalmology clinic and not directly caring for hypertension, immunizations, A1C, etc. Would this fact affect us negatively in, whoops, sorry, and then my question cut off. Here we go. Would this fact affect us negatively in the quality measure area? No, it would not. The reason being is that there are lots of measures specific to ophthalmology. There are measures about all sorts of different eye cares, and your eligibility for any given measure is based on how you bill. You can be eligible for measures related to immunization and hypertension. That doesn't mean those are the right measures for you. And certainly as an ophthalmologist, you might want to focus more on diabetic eye exams, open angle glaucoma, other measures like that, that really have to do with how you are seeing and treating your patients. The other thing I would say is that as a ophthalmologist, you might be able to consider the rainbow effect, or excuse me, the halo effect, which is where you could potentially get credit for high quality care that a patient is seeing in or receiving in another setting. But particularly for ophthalmology, there are several measures that really are focused on what you do. So those would probably be a better option for you than those primary care measures, which are quite frankly outside of your scope.
All right. Couple questions coming in here. We have a question from Bambi. Is primary care first something that a practice must choose? A practice received an email that they must enroll by 10/9 to participate, so I'm not sure what to tell them. That's a great question. That is primary care first is a new alternative payment model from CMS. It's an evolution of the CPC Plus model, and applications for the first cohort were due earlier this year. So it's no longer, unless you were part of that first cohort application process, other practices cannot participate at this time. They do anticipate a second cohort opening for CPC Plus practices sometime in 2021 for a 2022 start date. So if you're in the primary care setting and you'd like to learn more about that program, please do reach out to us because we have an exciting analytics and consulting offering to help you prepare and succeed in that new payment model, which boosts essentially the revenue to your practice so that you can really innovate in the advanced delivery of primary care. So very exciting stuff coming from that alternative payment model.
The
Bridget,
only other thing I just want to add to that, Charles, is that if the practice has received communication saying that they have to enroll in primary care first, it might be that they already participated in some level at the first cohort. And so it's really important to just follow up and make sure that you and the practice are both clear about what's going on, so you don't miss out on something you've already signed up for.
Yeah, absolutely. And speaking of that, we did distribute to our primary care organizations earlier this week a reminder that if you were accepted to that program, you need to, as part of your acceptance packet, specify a vendor that you're working with as a qualified registry. So if you were accepted, you need to specify a vendor, and we're ready and would love to be your qualified registry vendor for that program. So again, please do reach out if you're interested. A quick question from Carrie. Will you send out the PowerPoint with the handouts? Absolutely. Those will be out with the recording later this week. Another question here, Bridget, I wonder if you could go to the quality performance slide and speak to what does it take to improve performance for a measure? Kind of a big question, but I wonder if you could share some top tips with the audience.
Absolutely. So the quality measures, as we've mentioned before, your eligibility, which ends up being your denominator in the equation, is based on how you bill, demographic information. And your performance, which becomes your numerator, is based on how that particular patient or visit satisfied the measure. So let's talk specifically about a pretty straightforward measure here. Let's do tobacco use, which is measure 226. So for tobacco use, one way that you can improve is set up as part of your patient registration a screening question on tobacco use. Do you use tobacco? One of the great things is that if we can work with you and get data and give you analysis, let's say in June, you then have 6 months to put a process in place where you're screening every patient and therefore could report met and boost that score. Some measures are a little bit more challenging to do that with. Some measures really take a lot of detailed workflow changes. For example, we have the 2 depression measures here. They are measures that tend to be more challenging to calculate. And so if you're seeing poor performance, maybe you really are screening for depression appropriately, but it's just not being documented in a way that is discrete. It's not being documented consistently. And so really that's another way that you can really boost your score. The 2 reasons that people have low scores in general, the most common one that we see is they just don't have access to the right data. Most practices are giving good care to their patients, but if you don't have access to the data, it's really hard to represent that. And then the second thing is that there may be times where you have some misses, and that's okay too. Sometimes that means that you need to edit a workflow, maybe do a staff education, or really think about maybe this measure isn't for my practice. Thinking back to our ophthalmologist, certainly your ophthalmologist shouldn't be doing depression screening. So if you're trying to report on that, you're not going to have a great score. So really, those are the most broad and general ways that we can boost performance. Now, I know some folks aren't able to start early in the year to really work on performance, and that's okay because this program is going to be here next year. So even if your score this year isn't where you want it to be, this is really an opportunity to look at the coming year and say, what can we do better? What can we start in January or February that's really going to serve us well throughout the rest of the year? All right, I have a question here from Brian that says, does the EP for the CQM have to be 100% applicable patient, or is 70% sufficient for successful MIPS data submission? So I think what you're asking there, Brian, is about the reporting rate. So if you have a provider who's reporting a quality measure, which is a CQM, we have to calculate the denominator, which is your eligible patients at everyone. So for example, if we look here at this A1C measure, this is saying that you have 341 patients that meet the requirements. They're the right age range, they have a diagnosis of diabetes, they were seen in an office setting, whatever the requirements are for the measure. You do not have to report on every single patient in order to be successful with MIPS. You do have to report on 70% of your eligible instances, so 70% of your denominator, in order to earn the full possible points for a measure. There are some situations where if you are not able to report on 70%, you might still be able to earn 1 point or 3 points. And that's something certainly your consultant could discuss with you. It is not required that you report on 100% of all of your eligible patients.
All right. I think that's the end of the questions for today. So I want to thank Bridget again for sharing your knowledge with everyone. And I want to thank everyone for joining us today. We are ready to be your registry partner for the MIPS program and the quality payment program and other programs that you're thinking about or are participating in and struggling with. As Bridget did speak to, MIPS is a gateway, a pathway to what CMS is encouraging around participation in alternative payment models, where practices take on risk, where they have specific metrics that they need to meet. So you want to get started with understanding the dynamics of what it means to measure quality. These programs are imperfect and challenging at times, but that big picture idea of what gets measured gets improved is what's at play here. And all of us are trying to do what we can to improve quality to meet the needs of patients, while also lowering cost and delivering value to the system and to the patients. So that's our goal here, and we'd love to partner with you to meet those needs in your organization. So thanks again, and look out for the recording and the slides later this week, and hope everyone has a great rest of your day.
Thanks, everyone.